I've seen a lot of
Okay,
tetanus,
can you hear me now?
but
All
I've
right,
never seen
perfect.
a patient with
All right.
tetanus who had even the basic series.
Go back to the PowerPoint.
I showed a basic series quite a while ago, so okay.
F5.
Plus you have to have an antecedent introduction of the tetanus. And just moving.
Slideshow,
Once
slideshow.
you move around, you're not using machete
From the
very
beginning.
much, so the
Okay.
chances of getting,
Thank you.
well, anyway, it's a whole different
1 minute,
argument.
we're good to go.
I was surprised more about the diphtheria than anything.
I didn't think there was polio.
Hmm?
Yeah, I didn't think there was any polio there.
Well, there's not been a case of polio in the Western Hemisphere in quite a number of years, and so I don't know where.
Been more than 30 years, right? Since the 80s, maybe? Early
Yeah.
80s.
Mm-hmm. So, but if one case got in, because it's a vaccine, I'm sorry, it's the vaccine-derived polio that they're more worried about.
Okay, that's good.
Okay.
You're being recorded, so if you sit right there.
Oh, I see. I'm not supposed to sit in front of the, or stand in front of the screen. Okay.
Yeah.
Great. All right. Well, thank you, Paula, for inviting me, and thank you, everybody, for showing up. I'm going to talk about penicillin allergy. It's not going to be an extremely in-depth, physiology-based talk. It's actually more important, I think, to give some basic facts and approaches to be taken by primary care physicians, and it actually applies very much to the inpatient world as well, where I do most of my work. Now, obviously, inpatient and outpatient are very different. In inpatient setting, people are monitored much more closely, and so while not being cavalier about challenging people with things they may be allergic to, it certainly is get a lot less angst doing it in the inpatient setting than you would in an office setting. So I have to kind of take that with the talk. The reason I call it the cost of the common untruth is that the amount of time that sometimes needs to be spent and the amount of mental energy needs to be spent in dealing with patients that may or may not have a penicillin allergy, in terms of finding out what the allergy was, what's the history, how long ago was this, what are the alternative agents I'm now forced to use because I think this penicillin allergy may be legitimate. This just takes a lot of energy, a lot of time, and really on the inpatient side, it is costly because we know that there are different outcomes based on using non-penicillin antibiotics, and higher costs and more Clostridium difficile and other things which I'll talk about. I'll start with a few quick questions for the audience here. So, which of these is a characteristic of a type 1 allergic reaction? And type 1 just meaning a rapid and severe. So is it mediated by IgE antibodies? Is the response to the triggering allergen, does it decrease with repeated exposures? It can be overcome by tiny escalating exposures to the allergen. It's primarily symptomatic in terms of arthralgias or arthritis. It only involves dermatologic manifestations or more than one of the above.
More than one.
Yes, that's correct. So it is mediated by IgE antibodies, and that's why these reactions are so dangerous. And this involves the activation of mast cells, degranulation of mast cells, which releases histamine and other vasoactive compounds, which lead to the manifestations of a type 1 allergy. Of course, the triggering allergen, actually over time, if you keep exposing someone to something they have a type 1 allergy to, they'll get worse and worse. So it doesn't actually decrease with repeated exposures. However, by desensitizing, in other words, giving exceedingly small escalating doses, you can actually overcome most type 1 allergies. It does not primarily manifest as arthralgias or arthritis, but more edema type related manifestations. So obviously not only dermatologic. So which of the following is not a manifestation of a type 1 allergic reaction? Wheezing, diarrhea or nausea, arthralgias, pruritus, or hypotension?
Diarrhea.
That's actually not true. It's actually arthralgias. Yeah, you typically don't have joint involvement from a type 1 allergy. Diarrhea is a manifestation of bowel edema and can be seen in type 1 allergy as well. So it's not just a, while we typically consider diarrhea as a response to an antibiotic to be a side effect, in concert with other systemic manifestations, is consistent with a type 1 allergy. Okay, which of the following is not a treatment for an acute type 1 allergy? I think this is pretty much everybody knows this one. But acetaminophen, epinephrine, antihistamines, or NSAIDs. Yeah. Well,
There has to be a EAB.
oh,
What's the answer?
oh, so acetaminophen is not going to help you. Yeah, Tylenol will not help if you have a type 1 allergy. Now this is speaks more to clinical scenarios of why being able to use penicillins is so important. Now, which of these infections is best treated with a penicillin? A beta hemolytic strep infection, that's A, B, or any of those groups, sinusitis, syphilis, an animal bite, or all of the above. Right, it's all of the above. Typically, first-line agent for any of these would be penicillin or penicillin type drug. And because you see many patients come in who may have said, oh, my cat bit me, my dog bit me, but I'm allergic to penicillin, now you as a clinician have to figure out what to give this person. So of these options here, can you give them clindamycin monotherapy, a sulfa antibiotic, doxycycline, Keflex and Flagyl, Levokin Flagyl, Cipro and Clinda, or more than one of these? Let's go through one by one. Can you give someone clindamycin monotherapy? No, you can't, because clindamycin doesn't cover Pasteurella, which is the main organism of most animal bites, at least cats and dogs. What about sulfa monotherapy? No, you also cannot do that. Yeah. Doxycycline. So doxycycline has been used prophylactically, but if it's actually infected bite, doxycycline is not sufficient to treat. What about Keflex and Flagyl? So two issues there. One would be, well, should I give someone who has a penicillin allergy Keflex? That might be something on your mind. But it turns out that Keflex, also the first generation cephalosporins, have very poor activity against Pasteurella. So Keflex and Flagyl would not be okay. A second or third generation cephalosporin orally with Flagyl, however, would be okay. So cefuroxime or cefpodoxime would be okay. What about Levokin and Flagyl? Absolutely okay. And ciprofloxacin and clindamycin, absolutely okay. So those two would be acceptable alternatives. But you see, kind of going through the mental exercise of trying to figure out what to put somebody on with penicillin allergy. It's just, you got to look it up, you got to stop, you ask more questions. So it creates some difficulties there.
What was the answer?
So the last two would be okay. E and F.
Yeah.
So some background statistics. If you just look at population-based data, how many people are going to say they're allergic to penicillin? Well, probably about 10% in the community and up to 20% of people admitted to the hospital. What does that actually mean? Well, if you dig deeper into it, about 9 out of 10 of these people at least actually has no allergy to penicillin. In fact, even a direct challenge with penicillin would not produce any type of reaction. So we know that we need some significant vetting to figure out who these people are that actually have the penicillin allergy so that we can more narrowly treat people that could benefit from a penicillin. So all of you, I'm sure, are very, very familiar with the common reasons for a false label of allergy. So one would be, I got nauseated after taking it for 3 days, so I'm allergic to it. That's something completely coincidental. They got a headache for some totally unrelated reason or a rash due to some kind of contact with something while they were taking the penicillin, and they'll associate it sometimes with the penicillin. Loss of tralogy sensitivity over time, that can happen. Someone was penicillin allergic 20 years ago or 30 years ago, but now if you re-challenge them, they no longer have the allergy. That can happen as well. And then my two favorite ones, my mom said I had a reaction when I was a baby. That's almost never a true penicillin allergy. And then my dad's sister, cousin, or half-brother was allergic to penicillin. Now, you maybe make the argument that atopic characteristics can run in families, so possibly there could be some legitimacy to this, but specifically for penicillin, that doesn't, I would not hesitate to give somebody a penicillin, say that after they're saying their mother had a penicillin allergy. That's not going to be a common problem. If you look at just incidence of reaction in the penicillin naive population in terms of anaphylaxis, which is what we're really all worried about, it's exceedingly rare. So oral exposure to penicillin, I mean, it's well under 1 in 100,000 will have this type of reaction. And I'm sure someone comes in and needs a penicillin, is penicillin naive. None of you has any type of issue prescribing Augmentin or amoxicillin with no history of any allergy. Rightfully so. The likelihood of any type of major problem is exceedingly rare. It is more common, however, with parenteral exposures, but still also very rare, 1 in 80,000, not anything you would think about before administering someone parenteral penicillin. And then the risk of causing death. So if you're really worried about that type of thing from a penicillin naive person, there was a study in Great Britain over 35 years with 100 million oral amoxicillin courses. There was not one single death. So it's not something that you should be thinking about when someone comes in and needs a penicillin. What's the problem from a medical usage standpoint for avoiding penicillins? Well, we know from an inpatient standpoint, it leads to longer hospital stays, right? Using oftentimes less ideal antibiotics for the infection you're trying to treat. It can lead to significantly more antibiotic use, end up cycling through different antibiotics. Increasing rates of Clostridium difficile associated diarrhea and colitis, MRSA, VRE, these are all problems. And a specific example, so MSSA bacteremia, which you may see as an outpatient, you may diagnose and send the person to the hospital. I see it all the time. If you have to use vancomycin instead of using nafcillin or beta-lactam for MSSA bacteremia, there are multiple studies showing poor outcomes. It's not as an ideal treatment than using a penicillin or cephalosporin. Now that's just talking about penicillin allergy, but if you're looking at cross-reactivity, and this is where things really get bungled up, is that someone with some type of penicillin allergy, the temptation is going to be to try and avoid all cephalosporins in these people. Now, it's actually a myth that there's a cross-reactivity of 10%, and that's a number that's been bandied about for decades. But the reality is that in many, many observational studies, the cross-reaction is probably around 1%. So exceedingly rare. So a little bit hard to see this study, but I'll walk through it. This is a UK study that looked at over 3 million patients who received at least one prescription for penicillin. And there was a subgroup that actually ended up getting a penicillin and then within 60 days got a cephalosporin. So they broke out these groups and looked at them. So in one group that had I like how they use ALE as a class, they use AL for a British study, but they use an allergic-like event is what they called a reaction such as anaphylaxis, urticaria, angioedema, erythema multiforme, laryngospasm, TEN, or drug-induced dermatitis. They considered these significant reactions. So of the 3,900 or so patients that had any of these reactions to penicillin, within 60 days, they ended up for some reason getting a cephalosporin. You can see only 43 of those 4,000 patients had a reaction to the cephalosporin. So very, very rare. And then just looking at the other group, which is patients that had no reaction to penicillin, so 531,000 patients, and then got a cephalosporin within 60 days, you can see 580 of those had a reaction to the cephalosporin. So, a significant number actually had some type of reaction to cephalosporin independent of their penicillin issue, or independent of not having a penicillin issue. So this suggests some other mechanism. There may be more of an atopic tendency in these types of people. They may have had similar reaction to a sulfa or something else. So again, just having a reaction to cephalosporin also doesn't mean that there was any connection with the penicillin allergy. So of those 43 patients that had a reaction to penicillin and then had a reaction to cephalosporin, you can see that in the right-hand column there, so only one had anaphylaxis to both. So if you're worried about getting someone who even has an anaphylactic reaction to penicillin, having anaphylaxis to cephalosporin, it's pretty unlikely, very unlikely. By far the most common side effect was urticaria, which kind of makes sense. That's what you'd expect, right? That's what we're kind of worried about for the most part. But urticaria is not life-threatening, and it's not a reason why you would a priori avoid a cephalosporin in someone for whom it was indicated for their infection. So which cephalosporins appear to be more associated with causing reactions in patients with true penicillin allergies? Well, the first generation cephalosporins are more likely, and that would be cephalexin or cefadroxil, or in the inpatient side would be cefazolin. What's the reason for that? It has to do with the side chain of the first generation cephalosporin and its similarity to the allergenic side chain of penicillin. The data, however, really suggests that with second, third, and fourth generation cephalosporins, such as cefuroxime or Ceftin, Vantin, which is cefpodoxime, and then the parenteral ceftriaxone, ceftazine, cefepime, there's very low or possibly even no cross reaction. So just a very practical example of this on the inpatient side. So there was a study that looked at the influence of reported penicillin allergy on surgical site infection risk. So patients who reported a penicillin allergy had 51% increased risk of developing surgical site infection, primarily related to substituting non-beta-lactam prophylactic antibiotics for cephalosporins. And those would be things that we do all the time. Your penicillin allergy will give you vancomycin preoperatively, or Clinda, or Gent, or quinolones, or Flagyl. So that's what they gave to 89% of the patients that are reported, or with a reported penicillin allergy. But in those that didn't report the allergy, obviously almost nobody got it. 18% got those alternative antibiotics. So not using the preferred surgical prophylaxis generally, which is cefazolin, directly led to increased surgical site infection risk. And this is something that we're looking at currently in inpatient at John Muir as well. So at the University of Washington, they looked at this extensively using ANSEF for surgical prophylaxis. So they looked at over 14,000 surgical cases. 1,700 reported penicillin allergy. So of those 1,700, they gave 282 of them, or 16% of them, cefazolin. And this included people who reported rash, hives, GI-related issues, and anaphylaxis. So 16% of those patients still got ANSEF, so first generation cephalosporin, as surgical prophylaxis. Not one had an adverse reaction out of 280. So very reassuring data. Okay, so because of that, they changed their perioperative protocol that everybody gets first generation cephalosporin unless the allergy to penicillin is literal anaphylaxis. So, laryngospasm, hypotension type of thing, or Stevens-Johnson, so a severe dermatologic reaction. Multiple societies recommend going ahead with penicillin or cephalosporin use. The ABIM Foundation in 2014, they recommended really thorough vetting of this penicillin allergy instead of just a priori avoiding penicillins. And other societies as well, as you can see, include the recommendation for penicillin allergies to skin testing, which is available, and I'll talk about it a little bit later. And penicillin allergy testing can also identify those 90% that truly are not allergic to penicillin. But again, just simple questioning can identify many, many more without going to those lengths. So there's plenty of evidence in multiple studies to suggest that patients who are low risk, it's safe to actually give them a penicillin challenge. So there are 3 studies that looked at direct oral challenges, almost 1,000 patients. So only 2% of them had acute positive reactions. So some kind of acute itching, something like that. And 54 of them had delayed reactions. All were benign. So benign meaning they didn't have to go to, they didn't need epinephrine rescue or have to go to the hospital or anything like that. So these are people, of course, who are not reporting previous anaphylaxis, right? So lower risk patients. So it's very, very safe to do this. So one institution, Kaiser in San Diego, they actually have an algorithm for this. So patients with any benign acute reaction to penicillin, they can be directly challenged with oral amoxicillin 250 milligrams. And if there was a more severe reaction, such as shortness of breath or anaphylaxis, or there's some clear reaction occurred in the past 12 months, they say, okay, we'll just do a penicillin skin test first and avoid penicillin until that point. But you'll notice Well, certainly the majority of the patients will fall into the first category. Of course, you're also not going to, like I say, orally challenge anyone with a major reaction such as a Stevens-Johnson or hemolytic anemia or anything severe like that. That's just common sense. So there is a company now called PrePen. I'm not financially involved with this company at all, but we do use their skin testing kit. And we've trained our medical assistant in our office to do the skin testing. It takes, I think, about an hour or so. It's actually not that difficult to do. And you can bill for it. It involves really 3 steps. And the first is a simple scratch test. They give you a very direct allergen in the kit, and then you dilute penicillin G kind of as a duplicate test, and you actually just drop it on the skin and take a very fine tool and just make a little scratch, like a wheel in the skin. Not an injection, but just enough to break the epidermis. Wait about 15 minutes or so with a control. If there's no reaction to that, you proceed to step 2, and that's intradermal. So just a subcutaneous injection of the same allergen and dilute penicillin and a control. Again, wait about 15 minutes. If there's no reaction, then we'd give amoxicillin 250 milligrams in the office, wait and see if there's any type of reaction. So to date, we've done this on about 20 patients who said they were penicillin allergic. We've had 1 that came up positive by skin test. So 5%, not even the 10% from the community. Admittedly small numbers, but again, showing that for the most part, it's quite safe. Now, what about the reverse? This is usually a question that comes up a lot. Someone says, doctor, I have a Keflex allergy, but now I have strep throat, something like that. Can you give them penicillin? So studies on this are significantly less robust. However, from a chemical standpoint, so the penicillin allergen is actually a very, very specific molecule. And that's why we can do skin testing for it. Whereas the cephalosporins, the allergenic component of each drug is very specific to that drug. There are some similarities, for example, aztreonam and ceftazidime, but wouldn't use either of those in the outpatient setting. But the side chains are very specific to each cephalosporin. So typically not very similar to penicillin, with the exception, like I said, possibly of cephalexin. However, I will say that on the inpatient side, you see plenty of people say they're allergic to Keflex or Ancef, and we've given those people Augmentin, Unison, Zosyn, you name it, really without any reservation, and we have never seen a reaction based on a cephalosporin allergy. Again, I don't have the numbers, it's very anecdotal, but our practice is to just administer penicillins to these people. So going forward, what are the challenges? Well, like I said earlier, the inpatient problem is much easier to tackle. You have a captive audience, you have nurses, you have crash carts, anything really bad happens with any drug administration, you can deal with it immediately. That's obviously going to be a source of a lot of consternation in the outpatient setting. You're going to write somebody a prescription, they're gone, you have no idea what happens, right? So that definitely has to be taken into account. Percentages or no percentages is going to be on your mind. I understand that. So on the outpatient side, again, what are the issues? One is you may not think it's that significant of a problem. Okay, I can't use a penicillin, but fine, I'll substitute clindamycin, I'll use something else. It's not that big of a deal. But like I said earlier, it does actually lead to more issues down the road, right? So this leads to longer and longer avoidance of penicillins when those penicillins are the correct, appropriate drug to use, increased MRSA, VRE, Clostridium difficile, things like that. And like I mentioned in the beginning, typically this is time consuming because then you have to think about what is the best second line agent for this, or you have to stop what you're doing, go on UpToDate, call somebody, that type of thing. So it is very time consuming. And the third thing, which I think is very interesting, and I've noticed this myself, is that having the electronic medical record, while very good for some things, is not really our friend in this case. And why is that? Because instead of you going through the history with each patient, you can actually look at their record and say, okay, I see that they've had these surgeries, they're allergic to penicillin, they're non-smoker, blah, blah, blah. And instead of going back and specifically asking them like you used to do in the old days with paper charts, so tell me about these allergies that you have, you just take it as dogma that the patient is truly penicillin allergic. When in fact, just asking a few simple questions, you could determine that yes, they are, or more commonly, that doesn't make any sense at all. This person's really not allergic at all. So what are our opportunities here? Fairly straightforward. We're using a lot of broad spectrum antibiotics, and this is very expensive and breeds resistance. Nothing earth-shattering there. And again, how can we save people time by avoiding the need for alternative therapies, or sitting there with the patient saying, tell me about all the antibiotics you've ever taken and what happened and this and that, right? Very time consuming. Where can we try and save some time and use the right drug? So I proposed this at the Quality Improvement Committee, which deals with the network, and trying to root out on a systemic level, where are these false penicillin allergies occurring and how can we take care of this? How can we save people time? Well, one thing would be anyone who comes in on their medical record that says they have a penicillin allergy, administer a second questionnaire. A lot of times just by doing that, you're going to eliminate a ton of these allergies. So ask, when did this allergy occur? Classic one. I'm 60 years old now. It happened when I was 5. Okay, probably not a real allergy, right? So something like that. What was the nature of your reaction? That's a classic one. People don't know what an allergy means. I got an upset stomach. They write that on there, okay, this is an allergy. Have you tolerated the medication since then? This happens incredibly frequently. I'm allergic to penicillin, but I've taken it, took it a couple years ago, I had no problem with it. Or I've taken amoxicillin. I'm allergic to penicillin, I've taken amoxicillin. Or I've taken Augmentin. So right there, you've eliminated a ton of people again. Have you taken a cephalosporin, right? So, oh yeah, I took Keflex for cellulitis I had. Then instead of you saying, oh, I got to give them clindamycin because they have penicillin allergy, now you know, okay, we just eliminated that. And I didn't even have to ask the patient, just on this questionnaire. And then, have you ever been hospitalized where you had a severe infection? That's where EMR actually might be very helpful. Then you can just go into the medication tab, filter for antibiotics, and say, oh, this patient got Zosyn, got Unison. Right there, you're done. So really, really, I think low-hanging fruit right there. Eliminate a lot of the issue with the penicillin allergy. Now, the higher level stuff, how do we really get down to it in people that we can't eliminate the possibility of significant reaction? So in-office challenge, like I said, what Kaiser does, if the allergy doesn't seem high risk, have them sit there for an hour, give them a dose of amoxicillin, see what happens. The data, like I presented to you, show the likelihood of a significant reaction or death is as close to 0 as you can get to. Really, really safe to do that. And the other thing is the penicillin skin testing. And the allergists do it, so ANI does it, and we do it at our office as well. It's really not difficult, and I'm sure if you're interested in doing it even in your own offices, it's not difficult to get that set up. It's just, someone has to put in the time to do it, so it's more of a staffing issue than anything else. But works great. We've had no problems with it. So please, I welcome any of your questions about this. I hope that you've seen my proposal that penicillin allergy is really not as scary as we all make it out to be. And,
how do you handle patients that adamantly refuse to take a penicillin medication because of their past history, even though you had dispelled as a probability?
That's a problem for any patient with any therapy. I think that's a difficult one to overcome. That's kind of a generic question. How do you convince someone to take any type of therapy they really don't want to take? But I think that the problem is really the time you have to take. Probably a lot of those people, if you could spend enough time talking to them, you could convince them that, in fact, mountains of data show that it's okay and there are safe ways to do it. And we do it in the office here. We'll give you a challenge, something like that. You could appeal to the significant risk of side effects, significant risk of C. diff. I don't like scare tactics, but over time, what tends to happen also is that people get more broad spectrum antibiotics, they tend to get more resistant infections. And especially with penicillin allergic patients, we see it in our practice a lot. For example, the women with UTIs keep coming back in. They say allergic to penicillin. If that's not well vetted, we end up starting to see them with E. coli UTIs that are sensitive to penicillin, Augmentin, and Keflex, all these things, and they're resistant to quinolones, nitrofurantoin. And next thing you know, you're saying, if we don't figure out what's going on with this penicillin allergy, you're getting IV antibiotics for simple cystitis, things like that. So there are significant down the road consequences to this. But to answer your question, it's difficult to convince somebody do anything they don't want to do, but it is important to try.
There's so many other peripheral things that this brings up. One is the amoxicillin rash, which really is more than the penicillin reactions in current, because so many doctors don't use penicillin anymore, especially on the outpatient. The only thing you really use it for is a proven threat. But amoxicillin is given for fever, sort of like an antipyretic. And then if it's viral, and you can make the diagnosis of mono for you sometimes.
That's correct.
Given to them when they get the rash.
That's correct.
And then they're stuck with a diagnosis. And it's just anecdotal, but I had a patient one time that was admitted to the hospital because of an amoxicillin reaction. And I just couldn't figure out, A, why this patient was so sick with it. And I thought maybe the reason she was admitted because her mother was a nurse in the hospital. And it wasn't until a few hours later that I was sitting in church that I realized what it was, that it really was a rickettsia. And so I quit church and went back to the hospital and treated for rickettsia. So,
So that's one of the classic coincidental,
mm-hmm.
right? So those have to be teased out as well. So there was an event that occurred around the time of administering penicillin or amoxicillin
Mm-hmm.
that now gives the patient the stigma of a penicillin allergy, when in fact that's not the case. Yeah. So definitely have to
very
think about
lucky
that.
not to see much rickettsia here.
Yeah.
Tough damn disease to treat or diagnose.
In free clinic medicine, where histories are often very difficult to obtain because of the resources of the patients. And if they are really adamant that they have an allergy, we're going to use an injectable penicillin, like for syphilis or such. Is a 30-minute wait period long enough, or would you advise an hour wait period of observation in those?
For an amoxicillin oral challenge?
Yeah.
In someone who's adamant, I would probably wait an hour.
Okay.
Yeah.
And if you
Or
don't,
you could refer the person for skin testing. Yeah, right.
these have no resources, so
No.
I don't think you're welcome to your
Right.
office. The issue though is if you don't give the challenge and go ahead with the injection, should they wait 30 minutes or an hour?
I would still probably recommend an hour. Most anaphylactoid type reactions occur within an hour.
Another element is some of the older penicillin for procaine.
Yes.
And
Excellent
actually
point.
it was a
Yes.
allergy to the
Yeah, that's
procaine.
right. Procaine is an allergen. That is correct. So procaine penicillin actually, in and of itself, the procaine could cause an allergy. And a lot of people, I think, were assigned as penicillin allergic because of that.
So do you think there's a medical legal, I don't live in this state, but I hear you have a lot of legal adventures around here. Is there, I mean, if they give you an allergy history of penicillin with a rash years ago, that slight chance of cross-reactivity with a cephalosporin, are you feeling any legal jeopardy to do that down here?
The question is about the medical legal aspect of this. It's always going to be on our mind. Our practice has been to be, again, inpatient, outpatient is a little different. I get where this is going. I mean, we're talking about maybe a 1% cross-reactivity, but again, really likelihood of anaphylaxis from a cephalosporin is exceedingly low, right? So a lot of potential reactions, but anaphylaxis is quite low. On the inpatient side, of course, we have zero hesitation giving cephalosporin, but you're right, on the outpatient side, even with the data, I think it is probably, the data show it's safe, but from a medical legal standpoint, is it on your mind, to give somebody Ceftin with that type of history? I can understand where you'd be reluctant to do that, but I think it is safe. And again, a lot of it is talking to the patient and saying, this is extremely safe. You may be nervous about it, but these are the things to look out for, because you're really not worried about an anaphylactoid reaction. So I think you can proceed, but it's a lot about the communication with the patient and documentation of that communication.
Again, in free clinic medicine, using cephaltraxone, especially for Neisseria, we use lidocaine as a diluent. And we teach our our volunteers, if they must ask about the lidocaine allergy. Is my experience is the lidocaine allergy could be a anaphylactoid factor. I don't know if the quantity is enough. If there's a question, oh yeah, I had some reaction when I went to the dentist, we switched to saline. Is the necessity there to ask about lidocaine allergy whenever we plan to use it?
That's a good question. I would think it makes sense to do that, right? Anytime you give somebody a medication, you want to know what their allergy history is. And a lot of people don't offer up a lidocaine allergy unless you specifically ask it. But then again, I assume lidocaine allergy is actually fairly rare as well. But probably should know that in advance. Have you ever personally seen an allergic reaction from it?
No, but I had a dentist friend that had a reaction in the chair, and it was fatal. So, I mean, his comment was that if you're going to have a lidocaine reaction, it's going to be more dramatic than even an anaphylactoid to penicillins.
That may be true. Yeah, so I probably would ask. Yes.
So what happens, like sometimes we give amoxicillin high dose to kids for hepatitis B, right?
Yes.
And sometimes, a lot of times it has happened like 7th day on the treatment, they get a rash.
Mm-hmm.
So in those kind of situations, what do we do? Like we stop the antibiotic that
Right.
time saying it's
Right.
an allergy,
Right.
right? But down the line, future infections.
Right. So that. Yes. So the question was about a delayed type allergy to penicillin. So delayed type allergy may not be IgE mediated at all. So not on that pathway, but more of an IgG mediated allergy, kind of like a contact dermatitis or something in that same way. So certainly challenging with a cephalosporin after that, I think would be very safe. Penicillin rechallenge, probably safe also, although probably would expect a similar reaction. A delayed type rash would occur again with the same mechanism. Yeah. But is it dangerous to do that? Probably not. Probably not. Now again, you can develop a penicillin allergy at any time. And this is something we can't forget. You could have taken 10 courses of penicillin in your life. The 11th time you have some type of anaphylactoid reaction. It can happen, but unusual.
So why do they use amoxicillin rather than just plain penicillin for the challenge?
I actually don't know the answer to that.
What's the question?
Why use amoxicillin instead of 10VK for the challenge?
You don't have to use it as often.
No, but just for a single challenge. For a single oral challenge, I don't think it makes any difference one or the other. Yeah.
So they're 100% equivalent. So if you get a negative with amoxicillin, you're safe to go penicillin.
That's my understanding. Yeah.
Yeah.
Yeah, but Dr. Knoll's point is correct. If for treatment doses, amoxicillin is dosed less frequently, and that would be the reason why we use it more often than PEN-VK. Right?
Because I remember in the old days, when I started practicing in the early 60s, it was Perlroth. That's, we talked earlier about it, with the injection, where you're more than not the moiety with penicillin, but with this dissolvent. Really gave us a problem. So these people carry that history over, don't they, all the way through their lives.
Right. There was a question about the procaine that came with penicillin causing a lot of allergies with administration. Yeah, which is not as much of a problem now, and that's well recognized now. Which before I think a lot of the assumption was it has to be the penicillin aspect of it. It's actually not true.
Thank you very much.
Absolutely.
Thank you, everybody. Appreciate it.
Hardly anybody uses CR bicillin anymore. We used to use it a lot for prophylaxis in terms of rheumatic fever. But two things. One is the price. Lately, like everything else, but just plain old CR bicillin is just one else.
Yeah, I have a patient who was referred to me for a rheumatic fever, and it's kind of a questionable diagnosis, but I couldn't come up with anything more probable. She's an adult.
2 majors and 2 minors.
Yeah, right. So she's elected to do monthly bicillin instead of doing daily prophylaxis by mouth for whatever reason. So, okay. So we'll see if she comes back to me saying, wait a minute, this has gotten expensive. I don't know if it hasn't happened yet.
I helped with some of the manufacture process of bicillin. The early bicillin, the tubex was at the part of the needle that went up into the bicillin was straight. It's not straight now, it's bent. But previously you could inject it, especially into the buttock,
Yes.
and even if you aspirated, you got spasm of the superior gluteal artery, and therefore you did not know that you were in the superior, and there were many problems with this. Slumping of the buttocks was the most common, but getting into the vertebral artery and causing paralysis is another. So I wrote a couple of papers on this, but I just made a little twist in the needle part that goes up into the tubex so that you don't.
It was great to see you. I'll let Patty know I saw you. She retired very recently. New baby, new grandbaby.
Oh, I see, guys.
So you see.
Grand is important in that.
It kind of rifles, right? Is that some kind of?
Well, yeah, because
Yeah.
incidentally, my wife has had anaphylaxis at home twice. We have,
You know what from?
yes. The first one was acryprel, and the second was crab.
Oh, boy.
So now we have my homemade anaphylactic kits in cars and certain places in the house. Keep an ampule of epinephrine and a TB syringe all over the place.
Thanks, Jeff.
Thank you. Well, fortunately, Acupro is easy to avoid, and most places serve imitation crab. So, well, if my wife developed a crab allergy, that'd be trouble.
Okay, I'm stopping the cloud recording now. I figured out how. Do you want to stop cloud recording? I'm saying yes.
I wish you could